Good morning, students. I think all of you got your papers, marks for second internal. Any queries regarding that? Marks? Okay, we will speak it later. Now we'll start that tumors of nose and PNS. Most of the last topics, reaching last topics. Coming to the classification. Okay, these are the names you just need to know. Just squamous papilloma, encephaloceles, glioma, and all already I told in previous class. Dermoid, schwannoma, osteoma, chondroma, osteoma, fibroma, and all. Intermediate, this inverted papilloma. This is a short question for you. Inverted papilloma, meningioma, hemangioma, hemangiopericytoma, thalassocytoma. Malignant conditions are squamous cell carcinoma. They may ask, yeah, I think it's for PG's postgraduates. Squamous cell carcinoma, the maxilla. Okay, you also need to know this regarding that. Okay, adenocarcinoma, adenocystic carcinoma, olfactory neuroblastoma, so on. Okay, coming to the important one, that is inverted papilloma. This is a benign neoplasm. It's also known as Schneiderian membrane because it's derived from the non-olfactory membrane of the nose. What's the tumor arise from the olfactory membrane? Olfactory neuroblastoma or ischio neuroblastoma. Okay, this is it's arise from non-olfactory region. This is Schneiderian membrane. Okay, it accounts for 5% of all benign tumors. And so these the other names are important because they may ask you with this name. Okay, what is Schneiderian papilloma? What is Ringer's tumor? What is transitional papilloma? Okay, so you should know the other names of this inverted papilloma. Regarding it, is a locally aggressive cyanonasal tumor. Told you synonyms are Ringer's as Schneiderian papilloma. It's more common in males, phase 50 to 70 years age. It arises mainly from the lateral wall of the nose. It presents as unilateral, friable, pale pink mass arising from the middle meatus. You may mistake it as a polyp also. Okay, it's the diagnosis made by punch biopsy. Why it's called inverted papilloma? It's growing towards the stroma. The epithelium goes in strands towards the stroma. Okay, that's why it's called inverted papilloma. Unlike other epithelium, it grows inwards. Okay, it's most common cause by etiology by human papilloma factor, that is human papilloma virus 6 and 11. Okay, is the tendency to recurrence is more. Okay, that's very important here. Even after removal, the chances of recurrence is more for inverted papilloma. Okay, and it is associated with squamous cell carcinoma in 10 to 15% of the cases. That's why we have to go for surgical excision. Okay, what are the clinical features here? When it is unilateral, there is obviously unilateral nasal obstruction and bleeding from the nose, and nasal mass, it's something I told you, like a polyp. Okay, there is a bone erosion, thinning, remodeling, and sclerosis will be there. Okay, see this thinning of the bone. Habitants areas with linear calcifications. See this linear calcification here. With the treatment, the investigation is mainly biopsy, sent for histopathological examination, and treatment is this locally aggressive tumor. It may also involve the orbit and even sinuses also. Okay, treatment is mainly medial maxillectomy, the endoscopic medial maxillectomy, and externally you can do by lateral rhinotomy surgery by Moore's incision. This is important. They may ask you in Viva, what is the lateral rhinotomy incision? You should tell Moore's incision. Okay, what is the surgical treatment for inverted papilloma? Tell medial maxillectomy. Okay, see this is Moore's lateral rhinotomy incision. starts from the middle canals of the eye, goes along the nasomaxillary groove up to the halo of the nose. Okay. See, the tumor is removed and incision is closed. Okay. The other methods are like mid-facial degloving. You should know the names, mid-facial degloving approach. Okay. By sublabially, do incision like this. That's a tumor. This is a endoscopic medial maxillectomy. Endoscopically, to do MMA middle metal antrostomy, to remove the inferior tablet completely, to make a complete removal of the medial wall of the maxillary sinus. Okay. This is a hemangioma. Here I want to just ask you, so what is the most common benign tumor of the nose? Anybody? Most common benign tumor of the nose. Most common benign tumor of the nose is hemangioma. Okay. Most common benign tumor of the ENS, paranasal sinus, is osteoma. You should know. Then asking this examination, entrance examination. Most common benign tumor of the nose is hemangioma. Most common benign tumor of the paranasal sinus is osteoma. Okay. In osteoma, frontal sinus is most common. Okay. What's the most common malignant tumors of both nose and PNS is squamous cell carcinoma, followed by adenocarcinoma. Okay. So you should know about this hemangioma. So capillary bleeding polypus is also known as bleeding polypus of the septum. They may ask you two marks question. What is bleeding polypus of the septum? Okay. Soft dark red pedunculatus SL mass arising from the anterior aspect of the septum. Most common feature epistaxis. Excision is the main surgical treatment. Okay. Coming to the ossifying fibroma. What is the other name? Fibrous dysplasia. Here, what will happen? There will be normal medullary bone is replaced by the abnormal proliferation of fibrous tissue, resulting in distortion and expansion of the bone. Okay. Facial disfigurement. Okay. Fibrous CT scan by doing CT scan will get to know ground glass appearance with regions of osteolysis and calcification. The treatment is complete surgical excision. Here you need to know about the difference between osteoma and fibrous dysplasia. I told you, osteoma most common in frontal sinus. Here fibrous dysplasia most common in maxillary sinus. Here bone is replaced by fibrous tissue. Here mostly osteomas are asymptomatic. In some cases to obstruct the frontal sinus and cause mucocele. Okay. If only symptomatic only, we have to do the excision. Here, obviously, that bone replaced with fibrous tissue, there will be proptosis, nasal obstruction, and facial disfigurement. That's why surgical excision is must here. Here, see the osteoma. Okay, this is fibrous dysplasia. This is osteoma. This is a fibrous dysplasia. As a treatment in osteoma. See this procedure named osteoplastic flap technique. This is the hairline. You can see here. See, this is incision line. Okay. Incision line. Incision line like this. The hairline. Or to give incision like this and make the flap anteriorly like this. And osteoma, you should expose the osteoma. Okay. Tumor removed completely by drilling method and closing the bone flap. Okay. That's regarding most common benign tumor of the nose. Okay. Coming to the malignant tumors. In malignant tumors, the incidence is 0.5 to 1 of 1 lakh patients. It's most common is less than 1% of all carcinomas. Male to female ratio is 2:1, and most common in whites. Most common age is 55 years, above 55 years. Okay, I told you, maxillary sinus carcinoma is the most common. It's an important question for postgraduates and even for UGs also. Okay. Coming to the malignancy of the maxillary sinus most commonly involved, it's followed by ethmoid and frontal sinus. Squamous cell carcinoma is the most common histological type. Adenocarcinoma is common in woodworkers. Okay, this is the entrance examination. Adenocarcinoma most common in woodworkers. Here also some hardwood dust and softwood dust. If it is softwood dust, squamous cell carcinoma is more common. If it is hardwood dust, so adenocarcinoma. Okay, that's also you should know. Okay, as far as just for a remembrance, softwood dust for squamous cell carcinoma. Okay, nickel refining, boot shoe, textile workers are all risk factors for this carcinoma. Okay, the roots of spread. Here you need to know where is the maxillary sinus located, what are its relations. Then only you'll get to know what is the spread, how it spreads. Okay, anteriorly, posterior, and that. No need to mother. Okay. See the maxillary sinus here now. Maxillary sinus, superior spread to orbit. Okay, medial spread to the nasal cavity. Posterior spread to the maxillary posterior of the maxillary sinus, followed by pterygoid plates, pterygoid area. Okay. Inferior spread to the mouth and hard palate. Anterior spread to the cheek. Okay. Even superior spread to the cribriform plate through brain. Okay. These are the routes of spread. Depending on the route of spread, the symptoms are oral, nasal, orbital, facial, followed by CNS symptoms. The oral symptoms here, I told you, due to inferior spread, there is a alveolus and palate will get involved. It's seen in 25 to 40% of the patients. Mainly, dental extraction is loosening of the teeth, dental malabsorption, trismus, these all are the symptoms. So the nasal symptoms because of the medial spread. Okay, it's seen in 45 to 75% of the patients. Mainly, because the maxillary sinus is bilateral, mainly it is a unilateral nasal obstruction and nasal discharge is blood stained. What are the orbital symptoms? Orbital because of symptoms because of superior spread. Seen in 25% of the patients, and there is a lid swelling, epiphora, and the other features are diplopia, proptosis, and impaired vision. Okay, coming to the facial symptoms, mainly due to the extension of the anterior wall. Okay, seen in 40 to 70% of the patients. Main features are numbness and paresthesia because of the infraorbital nerve distribution. Okay, the blunting of nasomaxillary fold, widening of the dorsum of the nose, and the ulcerative got fixity to the skin. If it is the fourth stage, there is a skin involvement also. Then I'll tell you the staging. You can see this is fourth stage. This is cheek skin involved, nasal mass and all. Okay. Coming to the neurological, when you get neurological symptoms in maxillary carcinoma because of the cribriform plate involvement, anterior canal fossa, the headache, anosmia, CSF lead from the posterior wall, controlled the pterygopalatine fossa, deep facial vein and trismus because the pterygoid plates involved, through orbital apex to the middle cranial fossa. Okay, what are the investigations? Investigations are mainly biopsy, diagnostic nasal endoscopy and biopsy, and CECT scan. CECT scan. Okay, contrast enhanced. Okay. Here you need to know the names, some classification of the names of the this one maxillary sinus carcinoma classification. Okay, one is Own-Green's classification. These are the names given Viva or even 2 marks question. If there is an imaginary line extending between the medial canthus and angle of the mandible. This is the angle of the mandible. Imagine from the medial canthus to the angle of the mandible. Okay. Then above one is called suprastructure, situated above this plane. It has poor prognosis. The structure growth situated above this plane has poor prognosis compared to the infrastructure. Okay, that has compared to better prognosis. That is important regarding Holmgren's classification. Okay, suprastructure has poor prognosis compared to infrastructure. Imagine a line from the medial canthus to the angle of the mandible. The same picture showing here. One more is a Letterman staging. Here, imaginary line, horizontal imaginary line passing along the floor of the orbit and floor of the antrum. Okay, and two vertical lines along the middle wall of the orbit. Okay, making and imagine this one. Okay, this is suprastructure, mesostructure, and infrastructure. Okay, it's suprastructure here and mesostructure and infrastructure. Okay, two horizontal lines of CW pass through the floors of the orbit and maxillary sinus, producing suprastructure, mesostructure, and infrastructure. Here, what are the structures in all in suprastructures are included in suprastructure are mainly sinuses, except the maxillary sinus. All the sinus like ethmoid, sphenoid, and frontal sinus are included in suprastructure. And you need to know what are the areas of the nose. Superiorly, olfactory area. This is olfactory area. Can the downward can the mesostructure on the that is respiratory part and maxillary sinus involved in mesostructure. Okay, in infrastructure, only alveolar pus are included in infrastructure. Okay, in suprastructure, all the sinus except maxillary sinus and olfactory region of the nose, and in the mesostructure, all the only maxillary sinus and respiratory part of the nose, and infrastructure includes only alveolar pus of the maxilla. Okay, it's a little bit difficult, but you can remember this one. Staging of the maxillary sinus at least. Okay, above one. Here, just remember in T1 staging that tumor is limited only to the sinus mucosa. There are no bony erosion. That is T1. Okay. T2, just remember it's involving the bones. It involving the bone, and inferior and medial spread main important. That's why tumor involving the hard palate inferior and middle meatus, nose medial spread. Okay, this is to accept these are involving inferior spread and medial spread. That's hard palate and medial meatus. Here, except see no extension to the posterior wall and pterygoid plates. Okay, this is important. And there will be no posterior spread. Just remember like this. Both are starts with P, posterior maxillary wall and pterygoid plates. That's why in T3 you will have involvement of posterior wall of the maxillary sinus. In T4 you have involvement of pterygoid plates. Okay, just remember like this. T3 there are posterior wall of maxillary sinus along with the orbital walls are involved. Orbital walls. Okay, orbit walls are involved. Those are mainly the orbit wall involved mainly from the maxillary sinus, floor and medial wall. Okay, this floor and medial wall of the orbits are involved. Okay, that is T3. Posterior of the maxillary sinus and walls of the orbit. That's mainly from the maxillary sinus. What are the walls are involved mainly? Floor and medial walls. And T4, what is left? Posterior wall is posterior wall of the maxillary sinus in T3. Exception from T2 is pterygoid plates. That's why you can write pterygoid plates. And if there is involvement of pterygoid plates, there will be infratemporal fossa involved. Okay. Here you need to know is here walls of the orbits involved. Then after if the orbits are orbital walls are involved, next there will be anterior orbital contents are involved. Okay, that is T4. More advanced. Okay, here walls are involved in T3. Here orbital contents also involved. That is a T4. Okay. Just remember like this: orbital contents are involved, and pterygoid plates are involved, and if the pterygoid plates, obviously infratemporal force are involved. Okay. In T4B means almost this related to brain. Okay. Let's say you can remember like orbital apex, ABC brain, middle cranial fossa, and cranial nerves. Okay. This is related. This is regarding T staging of the maxillary sinus. Okay. If you remember like this, you won't forget. One more thing is N staging. I think this is more important for postgraduates. Nowadays, there is not a distinction between postgraduates and UG undergraduates question paper and final. That's why you need to know all these things. Okay. Coming to the nodal spread. What is N0, N0, N1, N2, and N3? Okay. There is N0 is no metastasis. Okay. In N1, remember like this: in N1 less than 3 centimeters lymph node size, N2 3 to 6 centimeters diameter, greater dimension. In N3 more than 6. Okay. N0 no lymph node. N1 is less than 3. First size I am telling less than 3, and N2 is 3 to 6. Okay. N3 is more than 6. Okay. In N1 there will be single ipsilateral lymph node. Single and ipsilateral N1. N1 already single ipsilateral. Okay. In N2 there is a 2A, 2B, and 2C. I told you now N1 is less than 3. Okay. N2 is 3 to 6 and N3 is more than 3. In N2 there is a 3 subclassifications. Okay. In N1 anyway single ipsilateral. In N2A also single ipsilateral. Same thing, 3 to 6. Okay. In N2B there is a slight change. Okay. Not a single ipsilateral, multiple ipsilateral. Just changes this multiple one. Okay. In N2B, even N1 also single ipsilateral, N2A also single ipsilateral, but in N2B it is multiple ipsilateral. Multiple ipsilateral, the same size is same. I told you already. Okay. In N2C is important bilateral or contralateral. Also, all N1, N2A, N2B are ipsilateral. But here bilateral or contralateral lymph nodes. That's important. N3 is again more than 6 centimeters in greater dimension. Understood? Again, I'm telling this. N0 is no lymph node metastasis. N1 is single ipsilateral, less than 3 centimeters dimension. Single ipsilateral less than 3. N2 is regarding size. It is 3 to 6. But in N2A, single ipsilateral. Size is same 3 to 6. N2B multiple, that is N2B meta is multiple and ipsilateral, not single ipsilateral. N2B there is changes multiple ipsilateral. Again the size is 3 to 6. In N2C there is a bilateral contralateral. That's a bilateral contralateral. Okay, same size will be 3 to 6. In N3 metastasis more than 3 centimeters in greater dimension. Okay. M0 is not distant metastasis, M1 is distant metastasis. This is regarding staging. In stage 1, there is T1, N0, M1. In stage 2, T2, N0, M0. Stage 3, T3, N0, M0. Stage 4, T4, N0 to 1, M0. 4B and 4C. Okay. Here I want to tell one more thing. At 3, I told you now, posterior wall of the maxilla and orbital walls. T4 from 4, what I told you, pterygoid plates and infratemporal fossa and orbital contents because of extension. And even I told you in the previous slide, if there is involvement of cheek, skin of cheek, this is a 4th T4A. Okay, this also cheek involvement is there, means anteriorly the 4th stage. Or the surgical options. mainly total maxillectomy and radical maxillectomy with orbital accentration. Surgical precision and all not much needed for you, but you should need to know the names at least. Okay. And with craniofacial resection when there is involvement of cribriform plate and all the frontal sinus and all. Okay. This is called Weber Ferguson's incision. Moore's incision ki konja extension idi. Okay. Moore's incision is up to here. Okay. Which goes like from the this margin infra rim. Okay, up to lateral canthus here and along the philtrum. Okay, this is Weber Ferguson's. You know the names of this one: Moore's incision, Weber Ferguson's incision. Okay, for the maxillectomy cuts, also you should know at least names. Okay, total maxillectomy. It is torsorrhaphy, closing the upper and lower eyelids. See here, what are the osteotomy cuts? You need to know the bony cuts. Okay. Osteotomy to the floor of the mainly through the frontal process of the maxilla. See, this is the frontal process of the maxilla and lacrimal bone, along the lacrimal bone, along the floor of the orbit, and one more is along the zygomatic process of the maxilla, and here upper alveolus, and palatal osteotomy. This is palatal osteotomy. These are the bony cuts of the maxillectomy. See, like this. Understood? This way. Okay. Once osteotomy, you have to separate the maxillary. This is maxillary tuberosity from the pterygoid plates. This is pterygoid plates. Okay. Then mainly through, again I'm telling, frontal process of the maxilla, lacrimal bone, flora of the orbit, and zygomatic process of the maxilla. How you do this one? By using Gigli's saw. Okay. Osteotomy to the upper alveolus, and palatal osteotomy. See, using heavy chisel, palatal cut is accomplished. The palatal osteotomy is extended up to the posterior margin of the hard palate, up to here. Okay, this is the way of doing maxillectomy cuts. Okay, told you this Weber Ferguson's incision. This is the palatal cut. Okay, you can see this marking for palatal incision. These are the osteotomy cuts, floor of the orbit and all, removing from the maxillary tuberosity. Here the specimen showing total maxillectomy done and incision is closed. Okay, by doing Weber Ferguson's incision. Okay, this is the defect following total maxillectomy with orbital accentration, complete orbital accentration with facial skin excision. Okay. Here, what you do once that hard palate, this one is removed, there palatal defects will be there. You can use prosthesis or some reconstruction. Okay, facial skin graft, some graft you can use. If it is involving the anterocranial fossa and have to go and frontal sinus, then have to go craniofacial resection along with the neurosurgeon assistance also. Okay, so craniofacial resection. This just need to know the name. That is regarding important tumors of the nose and PNS. Okay. Here, main important topics in these questions I told you now. Hemangioma of the nose or bleeding pulpus of the nose and inverted papilloma. You should know the other names of it. Okay, and you need to know maxillary sinus carcinoma, the staging and all. That's important. Okay, and incisions, Moore's incision, Weber Ferguson's incision. These are important. Okay. Now, any doubts? Any doubts regarding today's topic? about your marks. Regarding your question papers and all, many of you didn't any diagrams for this epistaxis, anterior nasal packing, posterior nasal packing. You draw neat label diagram, you get stick more good marks. Okay, regarding that, and even cochlear implant also you can put diagram. Okay, and just I expected at least Quincy that incision drainage diagram hardly corrected some 32 40 to 50 papers, but hardly I saw one or two students drawn that diagram for incision drainage of Quincy. Okay, that is important. I think here any topics are yet to cover. Nobody is responding. In here topics, what are the topics yet to cover? I think we are almost covered more than 90 to 95% of the topic. Are you listen? Are you listening? Anybody? So, 5 minutes. 2 minutes. Okay. When will be your offline classes? Any idea? You also fed up with these online classes since last 6 months. I think your seniors, the preferred batch students have exams. Theory exams started actually, not started. This November 18th, the theory exams, and practicals also in our hospital only. Then December 4th. Okay. I think exams once they start conducting, we will start all your exams also most probably Jan, Feb. Okay. Read well. Any doubts you can message me. Okay. Thank you.